Ladies and gentlemen, if you can take your seats, bring your coffees, teas with you. I know it's a long day. We're almost there. And if there are some outside who are chatting, perhaps you can corral them in. Good afternoon. My name is Jonathan Marks. I am the director of the Bioethics program at Penn State. And it's my great pleasure to have been affiliated with the lab and the Edmund J. Safra Center for Ethics throughout the term of Larry Lessig's leadership. And I'm very grateful to Larry and all the staff for that opportunity. I'm also grateful to Michelle Mello for her input in designing this panel. Unfortunately, she's not able to be here today. In the Arcades project, Walter Benjamin wrote that knowledge exists only in lightning flashes. The text is the long roll of thunder that follows. So you've had some lightning rounds. We're going to be not quite as brief as that, but we're going to be relatively brief. It'll be 12 minutes each to give time for discussion. But I also want to say that there's another lightning flash which is going on, and that is, as we've seen today, Larry's initiative on institutional corruption has been the great lightning flash which has brought together so many disparate scholars working in various areas. And what you see today is the long roll of thunder which will continue long after the initiative ends. And so I think we're all extremely grateful to Larry and the staff for that. There can be no area more important when thinking about institutional corruption than its impact on public health. And that is indeed the topic of this particular session. In fact, I think it's fair to say that one of the motivating areas for the study of institutional corruption has been the practice of medicine, medical research, and the impact of the pharmaceutical industry on medical research and practice. And that is going to be the subject of the first two presentations. The first will be by Jenny Pham-Kanter, who is an assistant professor of health management and policy at Drexel, and then Erin Kesselheim, who is an associate professor of medicine at Harvard Medical School. After that, we'll take a slightly different direction. I'm going to talk about public-private partnerships related to food and health. And David Stuckler, who is a professor of political economy and sociology at the University of Oxford, is going to answer the provocative question, is big food the next big tobacco? So without further ado, I'm going to hand over the microphone to Jenny, and we'll take questions at the end. Thank you.
All right. So I have some good news for you and some bad news. So the good news is I'm basically a data geek, but I'm not going to be talking about any data stuff today. And the bad news is I'm basically a data geek, and I'm not going to be talking about data stuff today. So be kind. So the way this talk is going to go is, whoops, right. I'll start off with a little bit of concrete background. A lot of you already have this, already know about this, but I'll talk a little bit about conflicts of interest in medicine, which is a large part, but certainly not the only part of institutional corruption when we think about it as it is applied in health. Then I'll summarize my take on the institutional corruption approach to conflicts of interest in medicine, and then explore some theoretical and empirical aspects of taking this particular approach. So the story is drug companies like to give money to doctors, and these payments can come in a variety of forms. They could be small gifts or tchotchkes that have brands on them, but they can have larger value as well. So they can give doctors the opportunity to make extra money by offering them consulting contracts, or they can be of even larger sums, such as supporting research. And the problem with these payments is that they can create a conflict of interest for the doctor. So doctors may not act in the interests of their patients. Medical researchers may not act in the public interest. And the deal is that, so acting in the interest of people or entities, they're supposed to be acting in the interest of, they instead of doing that, they act in favor of their own financial interest. Now, historically, conflicts of interest have been viewed as an ethics problem, and the way I interpret that is it's been viewed as an individual problem, an issue of moral conduct, of what's right behavior and wrong behavior, or if you like, good doctors versus bad doctors. And so with the traditional ethics approach, generally the behavior of doctors and researchers are governed by a general set of professional norms. So I put here that the profession sets rules, but really they set guidelines for what constitutes what's done and what's not done. And those regulations, those guidelines are conveyed through training. Sometimes it's formal, so sometimes it's specific classes related to, or usually class singular, related to ethics, but most of the time it's through informal means. So the senior doctor is modeling a certain kind of behavior, and the junior doctors are observing and learning. And this is how the guidelines, or what's done and not done, are conveyed in the profession. So the focus has been mostly on self-regulation, because this is a highly skilled, highly educated population. They're grown-ups who can take care of themselves. And one consequence of that is that primarily only serious violations get penalized, but otherwise our doctors are given wide latitude in terms of their behavior and conduct. And in general, sanctioning doctors for doing what I call here sketchy, but in other contexts can be also called yucky things, but legal things is difficult and also infrequent, and both, basically. So, so much for the traditional ethics approach. I think it seems as if there's something to be gained by approaching conflicts of interest, or framing it in a slightly different way, with less focus on the individual and more focus on, or the badness of individuals, and more focus on the issue as a broader policy problem. And part of what's driving this is, I think most of us can agree that there's nothing inherently bad about physician-industry relationships. So for sure, firms benefit from it, from them. Certainly, doctors are able to provide important expertise. The drug development process is improved by consultation with them. So that's one side of it. And the other side of it is that there are also benefits to doctors. In terms of research, NIH and NSF, given their budgets, can only fund so much research. There's a lot of research that wouldn't otherwise get done if it weren't financed by private companies. And I put here primarily benefits to doctors, but obviously that also has some social benefits. There's some public goods benefits to research as well. And then the second bullet is, I put in brackets as obviously that's a source of controversy, but it's possible that there's actually some useful information that's conveyed to doctors as well through some of this privately financed process. So given that there's some relationships that could be beneficial to the system, maybe we can get some traction from changing the conflict of interest focus from the individual level to a system level. So the problem really becomes not one of badness or goodness or morality of individual doctors, but really a problem of how the system is structured. So once we decide we're going to take a system level approach, we have a number of choices of sort of the tools that we're going to use to do this analysis. We can take a sociological approach, we can take an economic approach, or an institutional corruption approach, and they're not mutually exclusive. So what I was hoping to do, the reason I'm not doing the data stuff is because this conference is the culmination of 5 years of Larry's institutional corruption project. So I thought it would be a good time to reflect on the institutional corruption approach and how it is affecting our thinking about these kinds of problems in healthcare. So here's my short summary of my interpretation of the institutional corruption approach, and that is, we're interested in the flow of money in the system, insofar as they lead doctors to systematically behave in ways that are not in the interest of their patients or in the interest of the public. And this includes both standard incentive effects, what economists like to think about and how people respond to changes in prices or costs or benefits, as well as non-incentive effects. And that includes mechanisms that we understand from psychology. And I'll elaborate on this in just a second. But what's really crucial about the institutional corruption approach is that it doesn't equate money with badness. So money in the system is not a bad thing, but what it wants to do is identify the flows of money that are dysfunctional, that are causing the system to not do what it's supposed to do, and that is to have doctors act in the interests of patients and the public. So I'll throw out some random thoughts and theoretical and empirical aspects of the institutional corruption approach with the idea that maybe this can help some of us researchers, maybe practitioners, think about where we want to go. Okay, so one theoretical dimension is that since institutional corruption focuses on flows of money, you could think about sort of what's the standard incentive effect of money. And for the problems that we're dealing with, what this means is, okay, we have dollars, we have money from firms to doctors that leads to the personal enrichment of doctors. And this in itself may not be a problem, but if the personal enrichment is at the expense of doctors' professional judgment and patient well-being, that's a problem. So what's important here in the incentive story is that the doctor's actions, so his prescribing, lab orders, and so on, directly financially benefit the doctor. That's what's creating the incentive for them to do certain things. And we can think about canonical cases, which has sort of been already worked out, which are straightforward examples of incentive effects, to think about how we want to apply it to the conflict of interest problem. So these may be considered, I guess, part of conflict of interest, but people have reached some consensus about the mechanism and how it works. So one example is that a doctor may have ownership stake in a medical facility, some imaging facility, for example, and anytime the doctor refers patients to that facility, they obviously, because of their ownership stake, get a cut. So every additional patient results in additional money, and so that incentive effect is very clear. Another example is the fee-for-service reimbursement system. And what that means is that insurers typically pay doctors for the services, for each service or procedure that they do. And that results in, if you get paid more for more services, every time you provide a service or do a procedure, you get more money. So the incentive effect is also straightforward there. In the interest of time, actually there are a couple of slides that I'll have to summarize. This is one of them, but basically this tries to think through if the issue is, well, doctors are writing prescriptions, branded prescriptions, are there ways for firms to basically reward the doctors for doing that? And the summary is that there are ways. Certainly firms have that information on prescribing, but that the payoff isn't nearly as straightforward as it is in these other incentive cases. So the payoff is going to be lumpy, and so it's not a straightforward extension. Other theoretical aspects, the one sort of wrinkle on the theory side is that when we think about the influence from that are coming from gifts and food, that actually requires a completely different set of mechanisms. So the stories that we hear for trying to explain how these gifts and food influence the prescribing behavior of doctors, they come in two forms. One is that the gifts or the food create salience cognitively, so that attention is drawn towards the firm or the product, and that induces greater prescribing. A second story is actually a sociological story that says that, well, when a drug rep gives the doctor some kind of gift, because of the existing social norms related to reciprocity, they create a feeling of indebtedness within the doctor, and so the doctor feels compelled to reciprocate in the way that he can, and that's increasing the number of prescriptions. So one issue here is the financial value of these gifts actually are much smaller than the prescribing value. And in that way, it doesn't fit the incentive model. And on the theoretical side, it requires two very different kinds of theories, right? One is very micro about how attention is drawn to a particular product. One is very macro about, well, these pre-existing social norms. And these two mechanisms are very different. Not only are they very different from each other, trying to explain the exact same thing, but they're also very different from the incentive explanation. So in theory, so in terms of the institutional corruption, thinking about what we could do on the theoretical side on institutional corruption, it would be really good to have a meta-theory to reconcile the theories that are operating at very different levels to explain the same phenomenon in conflicts of interest. So really quickly on the empirical side, it seems like there are two empirical aspects that we're interested in: the scope and scale of firm payments to doctors, and also an empirical record tying dollars to influence. And in brief, we want to be able to tie dollars to influence. So we want dollars to empirically to show that dollars are affecting doctors' behaviors. But mostly what we've been able to show is that firms give a lot of money to some doctors. And empirically showing influence is much, much harder methodologically than it looks. And so in terms of the goal of quantitative studies to provide actionable evidence, we haven't really been able to do that yet. So, okay. So just to summarize, because I'm bearing in mind at the time, so basically most quantitative studies have been able to document the flow of money to doctors, but we need to distinguish mechanisms. As Dennis was pointing out in the very first panel, there's the influence mechanism, where it's the dollars that are changing doctors' behavior, and there's what many social scientists would call the selection mechanism, which is that doctors are behaving in a particular way. Some of them are predisposed to behave in ways that are favorable to industry, and firms are selecting which doctors they're going to fund. These are two very different mechanisms that look the same in a lot of data, and for policy development, we really do need to clarify the kind of mechanism. The other aspect is that in empirics, what makes it hard is that there's non-linearity. So what I mentioned earlier, what we typically want is small number of dollars having a small effect, and large number of dollars having a large effect. But in some cases, like the gift story, we actually have a small number of dollars having a very large effect that makes it very difficult empirically to sort things out. So in short, many different theoretical and empirical aspects of the institutional corruption approach, but I think the most important contribution is the shift in discussion from the moral defects of individual doctors or drug companies to thinking about system and incentive effects and flows of money that can distort doctors' behavior. And I think part of Larry's legacy is that in conflict of interest policy, that we seriously take the institutional part of institutional corruption.
That's forward, that's back, that's a laser pointer.
Okay, good. Thanks, well, thanks everybody. It's a pleasure to be here, and I'm going to talk today a little about some intersections between FDA regulatory policy, public health, and question of institutional corruption. And this is my disclosure slide, and I want to thank, I've been a faculty affiliate of the Saffer Center for the last 5 years, and I want to thank Larry for his support of work that I've done with them, as well as for support of Kirsten Ostad, who worked in our group during the first year of the fellowship. So, So my agenda today is to talk about the FDA expedited development and review programs for approval of new drugs, and talk about a little bit of data on their use, and then to ask the question about whether or not this is evidence of these data are evidence of institutional corruption. The data I'm going to present are unpublished data, so if you're live tweeting this or whatever, do keep that in mind. That eventually we're going to publish this in a peer-reviewed journal. So the current drug approval standard is based on legislation originally from 1938, which required the FDA to certify that a drug was safe before it was approved, and then updated in 1962 to require manufacturers to submit proof of efficacy as well as safety and affirmative action on the part of the FDA. And demonstrating efficacy required manufacturers to do studies to prove that a drug had substantial evidence that it was going to have the effect it was purported or represented to have, and that substantial evidence was defined as adequate and well-controlled investigations. Adequate and well-controlled investigations are defined in FDA regulations as studies that have a clear statement of purpose, a valid comparison, employ suitable methods to assign study and control groups. And basically, developing this work led to the enumeration of the 3 phases of research that investigational drugs go through before they can be approved and used widely in the public. The phase 1 studies in healthy volunteers to determine a safe dose of the drug. A phase 2 study which shows the initial efficacy data in a very limited population of patients, and then the final phase 3 larger controlled studies that tend to have these definitions in their design. And the FDA has generally required the testing of experimental drugs in 2 separate phase 3 studies. Although that has, it takes a flexible approach to applying that standard. Nonetheless, the enumeration of this standard leads to this system where the testing of experimental drugs can take a little bit of can take a long time, and drugs that end up proving to be safe and effective leads to a delay in availability of those drugs during the testing period. Again, in hindsight, for those drugs that were originally safe, proven to be safe and effective, and then secondly, it can be very expensive. So in response to that, the FDA and Congress have developed a number of exceptions to these rules in order to try to promote development in certain circumstances. So the first of these was the Orphan Drug Act, which was passed in 1983. Given the fact that the drug development process can be expensive, the Orphan Drug Act provided a designation for drugs intended to treat rare diseases that was supposed to give a signal to the FDA about these rare disease drugs to try to encourage approval of drugs for rare diseases, because otherwise there may not be in the market, there may not be an incentive to invest in the development of these products because of their limited market. In the mid-1980s, as a result of the HIV epidemic, HIV activists twisted the FDA's arm and got them also to develop a number of expedited review programs to allow drugs to be approved quicker on the basis of less data of efficacy and safety. So the first of these programs was the Fast Track program, which was developed in the mid-1980s and then formalized in 1988, that allowed drugs to be approved on the basis of a single phase 2 trial instead of the phase 2 and phase 3 trials. And it's supposed to be limited to drugs intended to treat life-threatening or severely debilitating diseases, and it had specific post-approval study requirements attached to it. The second of these developed around the same time, was formalized a few years later in the accelerated approval process. Accelerated approval allows approval of drugs on the basis of surrogate endpoints. So instead of showing that the drug actually affects symptoms or affects mortality or affects hospitalization, so things that patients really care about, you can have a drug approved on the basis of change in a lab test or some other kind of surrogate endpoint, as long as that surrogate endpoint is reasonably likely to predict patient benefit. And again, this is intended to apply for drugs treating serious or life-threatening illnesses or to provide a meaningful therapeutic benefit over existing treatments, and also has required post-approval study commitments. the final of these was created in 1992 with the Prescription Drug User Fee Act, which forced the FDA to accelerate its review of drugs, and for drugs that were determined to be priority review, required the FDA to act on them within 6 months of their submission. So for a drug to be priority review, again, it has to treat a serious condition that, if approved, provides a significant improvement in safety and effectiveness over other available products. So the outcomes of these programs have been to reduce the development time of drugs quite substantially. Under fast-track drugs have an average development time about 3.3 years less than drugs not in fast track. For accelerated approval, the total drug development time was found to be under 5 years. As a result of the priority review program and the Prescription Drug User Fee Act, the average duration of the FDA review of new drugs fell from about 30 months in the 1980s to currently about 10 months, and drugs for rare diseases are now the fastest growing subset of drug approvals. And there have been a number of major successes that can be pointed to of drugs approved via these accelerated, expedited pathways, including protease inhibitors for treatment of HIV, and imatinib or Gleevec, which is a transformative drug in the treatment of cancer that received all 4 designations, leading to its approval after only 2.5 months of regulatory review. However, at the same time, there have also been efficacy and safety concerns related to drugs approved via these pathways. Drugs receiving faster reviews in some studies have been shown to have a higher risk of adverse reactions. We did a study looking at cancer drugs approved via the orphan pathway as compared to cancer drugs approved via the non-orphan pathway, and found that orphan cancer drugs had a 72% greater odds of serious adverse events and a 61% greater odds of death, although that wasn't a statistically significant increased odds. But again, just showing that patients taking the drugs approved via these pathways have an increased risk of association with these adverse events. Dan Carpenter did some work showing that drugs approved closer to an administrative deadline were more likely to be withdrawn later. Again, showing that applying something like priority review, requiring the FDA to act in 6 months on a basis on an arbitrary deadline, on the basis of a serious drug that requires you to look at this, is a good idea, but applying it arbitrarily may be problematic. And then, of course, there have been a number of problems with surrogate endpoints used in approval of drugs. There have been a number of surrogate endpoints that have later been demonstrated not to be associated with positive patient outcomes, and this is just a partial list of some of those surrogate endpoints. And that leads to conditions, to drugs like this Mylotarg drug, which was approved on the basis of a single phase 2 trial, open label study in 100 patients, and ended up being withdrawn from the market 10 years later when a confirmatory comparative study showed actually no benefit in response rate or overall survival and an increased incidence of adverse outcomes. So these pathways provide potential benefits, but also provide important risks for patients. So this is some data on their use and how they've evolved over the last few years. So we took a sample of almost 800 drugs approved over the last 2 decades and categorized them on the basis of their innovativeness here in the bottom section to identify which were first-in-class as opposed to non-first-in-class products, and then did a series of logistic regression models to evaluate trends in the percentage of drugs receiving the designations over time. And so this is the basic results. We found that over time there's been a statistically significant increase in the mean number of designations granted to each specific drug, as well as a statistically significant increase in the proportion of drugs granted at least one of the designations over time. And so, you could say, well, maybe this just means that there are more first-in-class drugs being approved over time. And we found that that's actually not the case. If you separate out the first-in-class drugs with the non-first-in-class drugs, you can see that the statistically significant increase on the right-hand side here in the proportion of newly approved first-in-class drugs is related to the non-first-in-class drugs, not the first-in-class drugs, which is the red line. So what's going on here? Well, it could be an expansion, in the use of the designations in cases that are not consistent with the original definition of the product. So bimatoprost or Latisse, which is a drug was approved via the priority review pathway. This is the drug that's indicated for hypotrichosis of the eyelashes or to make your eyelashes longer. This is does this meet the definition of what a priority review is supposed to be applied to? There also could be disingenuous designations, so the lidocaine patch, was certified as an orphan drug for treatment of post-herpetic neuralgia, a very small condition associated with infectious disease. But actually, neuropathic pain is quite common. And we did a study looking at use of this product, and you can see that the off-label use of the product, as Mark Rodwin talked about, off-label use is quite common, and off-label use of this product for the non-orphan condition for use in neuropathic pain and actually in non-neuropathic pain is much more common. And then finally, there could just be overzealous designations and approvals. So this product was a cancer product that was approved in 2012 on an accelerated basis to treat a refractory form of cancer on the basis of a single phase 2 trial that at the time the drug was approved hadn't even been published. When emerging data from this trial and another trial of it came out showing increased risks of side effects for patients, the FDA had to pull back on the approval and then ended up reapproving it a few months later with a more limited indication and an enhanced warning system. So it leads you to answer the question of whether or not the exceptions are swallowing the rule a bit. If you look at all the drugs approved in 2012, about 2/3 of these qualified for at least one of the FDA's expedited approval pathways. And then there's the concern that the FDA is not able to hold up the other side of the quid pro quo, that the post-approval studies confirming these accelerated approval drugs is not being done as quickly as it should. And this is a study from JAMA in 2013 showing that the rate of post-marketing commitments that are delayed has risen from 2007 to 2011. Is history repeating itself? The breakthrough pathway was a new designation created in 2012 for, again, drugs treating serious or life-threatening conditions and required the FDA to expedite its development and review. In the last 2 years, there have been nearly 250 applications for breakthrough drugs. Nearly 70 drugs have been approved as breakthrough drugs or have been designated as breakthroughs. Here are some of the drugs that have been approved under this breakthrough label. You know, it's possible that there are 4 new breakthrough drugs for the treatment of CLL. I highly doubt it. I don't even know if it's possible for 4 breakthrough products to be approved for a single condition. But anyway, even the senator who created the breakthrough therapy designation has said that the rollout's been faster than he expected. So in my final, I guess, concluding summary thoughts, is this evidence of institutional corruption? You know, what is the explanation for this trend in designations at the FDA, and what are its implications for the public health? You know, is this just growing institutional comfort in the pathways? Is industry naturally directing resources towards easier pathways to market? Is this a reputational effect from the FDA trying to show that it's, you know, reviewing more products through the pathways available to it? Or is this a natural expansion in the definition of a serious and life-threatening disease as more patient groups are seeing that this is an expedited, quicker pathway through FDA approval and are so trying to get their diseases classified as serious or life-threatening as well? I'm sure it's, you know, there's a combination of different considerations here, but you know, the problem is that this leads to a diversion in FDA institutional resources. It is unclear whether physicians or patients understand differences in the evidentiary standards among drugs approved by the FDA via these different pathways. The FDA has limited authority to require post-market testing and then to withdraw a drug if it doesn't meet its goals. And of course, more designations are coming down the pathway. There's the qualified infectious disease product designation in FDASIA that requires the FDA to accelerate approval of antibiotics, certain kinds of antibiotics. And then in the new 21st Century Cures discussion draft currently being evaluated, there are designations such as the dormant therapy designation. So I think that it might be interesting to follow the natural history course of these designations and how they end up affecting the drug approval process that then ends up affecting the public health. Thank you very much. Uh-oh. I think I hit the wrong button. All right.
So I'm going to talk to you very briefly about public-private partnerships in public health. There are many people to thank, too many to acknowledge in a slide you would see so quickly, but obviously Larry, the lab, and my many fellow fellows. I'm going to be talking to you about public-private partnerships, which have become the paradigm for addressing public health problems and global health problems, and I have been analyzing the systemic ethical implications of these, thinking about not just trust, which is an attitude toward an organization based on perceptions of that organization, but I've been thinking about institutional integrity, which is an attribute, I argue, of the organization. And I'm particularly concerned with the institutional integrity of public institutions like the World Health Organization, like the UN, like national governments, like local authorities. And one way to think about integrity, this is not the whole of it, but a significant part of it, is to think about whether there is a consistency between what the institution says it does or will do and what in fact it does do, to explore whether there's a tension between the mission and the practices. And in the most extreme case, you might say that an institution whose practices predictably undermine the very goals in terms of which it justifies its existence lacks integrity. So bear that in mind as we talk about public-private partnerships. And I'm not going to define public-private partnerships because the term is so broad it captures too many things. In fact, that's one reason to jettison the term. But I'll just give you an example. Sanitation in schools in rural India is poor. This is a fundamental problem. It's a problem which is a gender equity dimension because when sanitation is poor, the girls drop out of school before the boys. No one could object to an initiative designed to address this problem, but I'm going to tell you about a public-private partnership to do just that, which in my view is highly problematic. This is a public-private partnership involving the UN Habitats Program, whose mission note is to promote sustainable living. Coca-Cola, whose color and logos you can see all over the screen here, and New Delhi Television. In exchange for gifts amounting to less than $1 million, Coca-Cola got a months-long high-profile campaign using its logo, trademark, and color schemes, as you can see here on the screen, and in addition, a 12-hour telethon during which it pledged the larger part of its gift. So for Coca-Cola, this was an incredibly beneficial partnership. The benefits, I think, are clear, and I'm going to tell you about the benefits in just a minute. But what you'll also note is that Coca-Cola produced this chart in which it showed all the partners. There are many others in addition to the ones I mentioned, but you can see that Coca-Cola puts itself right at the center. So let's just think about this in the context of global health. As we know now, obesity is a fundamental problem. It is as much of a problem, more so now, than undernutrition. And indeed, the Global Burden of Disease study published in The Lancet recently found that, quote, not only is obesity increasing, but no national success stories have been reported in the past 33 years. They also noted the associations with cardiovascular disease, cancer, diabetes, etc. My fellow panelist, David Stuckler, from whom you're going to hear in a moment, has in his own work reported on industry analysts' predictions that soft drink consumption will double in India over the coming 5 years. And as he and his co-author Sanjay Basu have also noted, soft drink consumption is significantly associated with population level rates of overweight, obesity, and diabetes, and that's a consistent and strong association, quote, even after correcting for other types of foods available on the market and for plausible controls, including income, urbanization, and aging. They predict that 1 billion additional adults will become obese within the next 5 years, accounting also for 192 million cases of diabetes, and that 60% of this burden will fall on low and middle income countries. So you can see why one might be concerned about a public health initiative designed to address one problem, sanitation in Indian schools, that may well be sowing the seeds of another problem, obesity, diabetes, and other associated diseases in India. And I don't think I really need to explain the mechanisms, but I will say just a little bit about them. So the mechanisms involve at least a couple of things. One is a sort of health halo effect, so that when Coca-Cola is associated in the minds of consumers with a public health initiative, it adds a sort of beneficial health halo, just as when, for example, the Subway food chain advertises itself as healthy, it affects people's perceptions of their food, and in fact leads people to discount the caloric content of their foods more than, for example, McDonald's, which isn't marketed as healthy. But also let me say something about the logo effects. Here's a study conducted by a team at Baylor, nicely summarized in a report on influence and reciprocity produced by the American Association of Medical Colleges. They told the participants in this study that the study was funded by generously funded by a corporation whose logo they were shown. They were then asked to say whether they liked or disliked on a Likert scale of 5 to -5 various paintings, including this one, The Bigger Splash by David Hockney. The logo of the fictitious corporation was flashed at random alongside these paintings. And, surprise, surprise, was correlated with, when the image was flashed, this correlated with a higher approval of the painting. So there were subtle effects on people's aesthetic judgments. So one real concern is that in using all these logos and color schemes and the long advertising campaign to promote Coca-Cola, what the UN Habitats program has done is, in solving one problem, created another one. In fact, another one which undermines its own fundamental mission to promote sustainable living. So in my view, that clearly has an impact on institutional integrity and indeed also in trust in the UN Habitats program. Let me give you one other example. In the US Department of Agriculture, through its Center for Nutrition and Public Policy, is partnering with various corporations, including snack food companies like Frito-Lay and their public relations firms, in order to promote simplified dietary guidance to Americans. The companies sign a memorandum of understanding in which they state that they have a mission consistent with the dietary guidelines for Americans and a health mandate consistent with that of the unit in which the Center for Nutrition and Public Policy is housed, which in my view is a fundamental denial of the ways in which the missions of these organizations diverge. The CNPP's mission is to promote the health of Americans by developing dietary guidance that links research to the nutrition needs of consumers. That is not the goal of Frito-Lay. In fact, these companies also also attest that they have, quote, the common goals of ensuring the completeness and accuracy of all information on nutrition disseminated to the public. Well, as some of you are responding without necessarily articulating it, clearly that's problematic. Frito-Lay does not have an interest in Americans snacking on fresh fruit and vegetables. It has an interest in Americans snacking on their products. So, in my view, there's a fundamental denial, as I say, about the way in which the missions and interests of the USDA and its Center for Nutrition and Public Policy in particular diverge from the mission and interests of these corporate national strategic partners. A representative of the Center for Nutrition and Public Policy told investigative journalist Brooke Williams, also a lab fellow, that this partnership program expanded the reach of the center in communicating dietary guidance. But what she didn't recognize was the way, in fact, that it impairs the CNPP's mission and its credibility. In fact, CNPP encourages corporations to sign up because of the, quote, credibility associated with federal government partnership. But they don't address the lack of credibility that comes from the federal government in turn partnering with, for example, snack food companies. So, let me just say a little bit about some of the implications of this. These partnerships are often promoted, for example, here by the US Secretary of Agriculture, Tom Vilsack, as a win-win-win for the USDA, corporations, and for us, framed, by the way, as consumers, not as the public. But I think it's important to note there are some other perspectives. This one doesn't come from left-wing activists, but indeed from a former executive vice president at Kraft Foods, Michael Mudd, who wrote in the New York Times, Next time you hear of a big food company or beverage company sponsoring an after-school physical activity program, you can be sure they'll say it's to show our company's concern for our kids' health. But the real intent is to look angelic while making consumers feel good about the brand and drawing attention away from the unhealthful nature of the company's products. Posing for holy cards, as one of my colleagues used to put it. Now, I actually don't think you need a Manichaean view of industry. Industry is evil, government is good, and you don't need that view in order to demonstrate why this is fundamentally problematic. In fact, children like my own, who are 10 years old, are directed to this government website, which explains the fundamental principle of separation of powers, which is not premised on the notion that the judiciary is inherently good and the legislature and executive branches are inherently evil. Rather, it's premised on the notions that not only must power be distributed, but in order to preserve the core functions of these bodies, they must maintain a distance from each other. In particular, the judiciary must maintain a distance from the legislative and executive branches. And so what I'm doing, and I don't have time to explain fully now, what I'm doing in my book, which is provisionally entitled The Perils of Proximity, I'm explaining a couple of core concepts. There are good reasons to maintain a separation between industry on the one hand and the academy and government on the other. That contrary to all the exhortations that we must solve problems of global health in consensus with industry, we are in fact putting off the table potential solutions like regulation to which industry will not agree. By achieving common ground with industry, we do not promote the common good. On the contrary, we may be putting off the table, possible solutions that may in fact promote the public good. I also emphasize in my book the perils of reciprocity. Reciprocity between two academics exchanging comments on their articles is fine, but reciprocity between bodies who have divergent missions and interests, in particular when one body, the public institution, has a mission to promote public health, and the other body has products, practices, or activities that undermine public health, reciprocity between them is problematic. And reciprocity in such a case, in my view, undermines the institutional integrity of the public institution and trust and confidence in that institution. I have some suggestions for the road ahead. I also have some principles, as does my colleague David Stuckler, on how to think about the systemic effects of public-private partnerships. But I will stop there and hope you will ask me in Q&A. Thank you very much.
Great, thank you very much. It's a tremendous pleasure to join you here at the end of the day, and I realize I stand between you and soft drinks, including Coca-Cola, down the corridor, so I will take a lot of time. My name is David Stuckler. I lead a team that focuses on social protection, which is in some ways a flip side of institutional corruption. And one thing we grapple with is how to get evidence into policy. An analogy I use with our team is that of crossing a river. As scientists, we produce a lot of data and analysis, and we try to cross Rubicon with our p-values, get our papers in Lancet, New England Journal, and finally cross the river to where policymakers reside on an island, only to land on those shores and find it's already full. It's hard to park the boat, and struggle to get elbow room to get evidence on the table. And what we've learned echoes what Jonathan said before, is that true power is expressed not just in getting things on the table, but in the power to keep things off. By now you may be wondering who is this charming gentleman, grandfatherly chap I have here. Some of you may know this is John Daly. He's the most powerful man in European public health, or I should say he was the most powerful man. For as European Health Commissioner, he was charged with the task of spearheading the Tobacco Products Directive. This is Europe's flagship program for preventing tobacco in kids and expanding prevention programs. Until Swedish Match, a tobacco company, accused him of fraud. At the time, last year, the head of the commission, Jose Barroso, called Dalli into his office and said he had 30 minutes to pack his things and go. Dalli protested his innocence, but felt he had no choice and took a golden parachute package out. Since then, the Tobacco Products Directive stalled. The day after Dalli was ousted, thieves abseiled from the buildings of European Parliament into my colleagues' offices at Smoke-Free Partnership, the European Public Health Alliance, breaking in, stealing laptops and their confidential lobby documents on the Products Directive. And then, in a case already stranger than fiction, the head of the investigation of fraud against Dalli resigned, and the case goes on. So this is a gentle introduction to say welcome to the real politics of the prevention and control of chronic diseases. For chronic diseases are not like threats in global health we've dealt with in the past. When you're dealing with malaria, you're dealing with a mosquito. But when we're dealing with heart disease, diabetes, and common cancers, we're dealing with powerful multinational industries that make and manufacture products that, in the case of tobacco, when used as intended, will kill half its users. And what we see, the point Jonathan made earlier, is that virtually all the profits of these multinationals are not coming here, but in developing countries. What you see here in the straight line is the trends in sales in tobacco. It's really saturated here in North America and Europe, but in the dashed line you see the projected growth in sales year-on-year change in developing countries. You can see the same for soft drinks. You see the blip in 2008, nothing like a global financial crisis to put a dent in soda sales. But again, the growth is really in developing countries. And thanks to the discovery of tobacco industry documents, we've learned a lot about the tactics that tobacco uses to shore up its markets. And some of you may remember in the 1950s when the evidence was coming out in the British Medical Journal that tobacco caused lung cancer. Big Tobacco lied. Here we have a frank statement to cigarette smokers published in the New York Times that said, "We believe the products we make are not injurious to health." We know from their documents that they had their own evidence showing the opposite. And as the evidence grew and it was no longer possible to simply deny tobacco's harms, tobacco generated a new strategy that they called Project Whitecoat. That was the name for scientists like myself and Jonathan, and they hired these whitecoats to restore the social acceptability of smoking. I'm quoting directly from industry documents, to reverse the scientific conception that environmental tobacco smoke is harmful, often funding groups, front groups like the Center for Indoor Pollution. That sounded quite credible. And as, again, threats of taxation started to come in, effective public policies were on the doorstep. Here we have the latest document from Philip Morris just a few years ago that's called Project Sunrise, Dawn of a New Day, which aims to create schisms to force people in public health to fight among themselves by working with them. And here you can see the language, proactively deal with the antis. Those are what they call tobacco control advocates, to create rifts between those focusing on youth and those focusing on adults, those focusing on prevention, those focusing on cessation and existing smokers. So it could go on about tobacco, but the big question I've posed today is how similar is big food and big alcohol? And one clue we have comes straight from the data, that they're in similar ways. There's a phrase where there's smoke, there's fire. What I have here is a scatter plot. These are countries around the world. Each dot is a country. And when you see more tobacco, you see much more alcohol, you see much more highly processed food, and more soft drinks. It's a clue, and we see it in the data, that these companies are using similar tactics sometimes through trade policies, to crack open markets and clear a regulatory-free zone to shore up profits. The other clue we've got is many were under joint ownership. Altria, a big company you may not know, jointly owned Kraft and Philip Morris for many years. And we still see interlocks between boards of directors where we find flows of people, funds, and activity across them. The second comes from the science. And in a journal I sit on the editorial board of, PLOS Med, we published a systematic review that took a scan of the literature in nutrition. And in the studies done, we found over half were funded by the food industry. And when the researchers looked to see, did the funding source, did getting funding from Coca-Cola or PepsiCo relate to the conclusion, they found that those which were industry funded were 7 times more likely to come up with a conclusion that favored the industry's bottom line. So is industry biasing science? Yes, they are. Now, here we have another example from the American Council on Science and Health. This is a group of regular commentators on Fox News. It sounds quite credible. My mother, for example, would think that this is legitimate. But they're funded by many of the usual suspects here, Kraft, Heinz, even pharmaceutical companies, to name a few. And here they write that research actually shows there's no correlation between per capita soda consumption and weight. This truth is conveniently ignored by those who need to pursue an anti-big soda agenda, oblivious to science-based evidence. They're talking about me here when we published a study on this topic. And they continue to say the focus should be on physical activity. It's clear that we are a population that's become too sedentary. Of course, physical activity is important, but what the data show, and this is the paper in American Journal of Public Health, is that there is a strong, robust association of soft drink consumption and health harms across nations. But never mind the aggregate evidence, they're now convincing randomized trials that show drinking more soda leads to weight gain in children. But the big point is industry using front groups to try to muddy the science? And again, yes, they are. Turning to physical activity, some of you may remember the Olympics, and this is common, seeing Coca-Cola sponsor sport in schools, football games, matches, and here the Olympics. And one you might have seen was Stephen Blair, the world's arguably top physical activity researcher, was sponsored by Coca-Cola to run with the Olympic torch, wearing a Coca-Cola jersey. Some of us felt this was a conflict of interest, especially noting that his Lancet series on physical activity didn't feel the need to note Coke funding as a COI. He disagrees, but the real issue is not whether he was right or wrong for doing so, but this has led to a big rift in the nutrition field, splitting those who are concerned about obesity, focusing on physical activity, and those who are concerned about us taking in far too many calories. So again, do we see signs the industry is creating schisms? And again, yes, they are. And when these tactics don't work, there's always the ones you may have recognized in New York City before the big hoopla about the size of sugary drinks. I was kept off the table. Initially, Bloomberg wanted to do a beverage tax that never got off the ground. And this has manifestations at the highest level. Here's an example of the World Health Organization. When it first published a recommendation to limit sugar intake in our diets to more than 10% added sugar of our total food consumption, the Sugar Association wrote, "We will exercise every avenue available to expose the dubious nature of the WHO recommendation, including pressuring Congress, US Congress, to scupper the WHO's funding. Taxpayer dollars should not be used to support misguided material." Now, WHO then stood firm. That was 2003. Flash forward now, and we see elements of the WHO partnering with Nestle to fund diabetes prevention programs. Or turning closer to home, the American Pediatrics Association newly launched a partnership with Coca-Cola to fund a series of childhood obesity institutes around the country. So if we're going to get serious about preventing chronic diseases, we're going to have to deal with these conflicts of interest. Self-regulation is not enough. What we propose, and I won't have time to discuss it, are some principles for these partnerships. Checklist. Do partners practice what they preach? Are there independent audits? And in a scan we did, most existing partnerships fail these basic criteria. The sum message is, we're with food where we were about half a century ago with tobacco. The price of inaction was staggering. And even today, less than 10% of the world's population benefits from policies in this building: smoke-free workplaces, taxes on cigarettes. We're only beginning this conversation. So my question to you is, how long will we wait? Will we wait to take a stand, to take action? Thank you.